Good morning everyone and a very warm welcome to all present here, respected principal, teachers, our lovely alumni and students. It is with great pleasure that I welcome you all to the 13th edition of KAA Talk. The Alumni Association April 2005 and is functional since then. Over the years, this platform has evolved into a space of insightful discussion, knowledge sharing, and thought provoking conversation, and today is no such exception. This meet also enables the alumni to notice the changes and developments happened in the college campus and feel nostalgic about it. Before starting this event, let us take the blessings from the Almighty. So I request everyone to please stand on their places. It is my privilege to extend a warm welcome to our esteemed principal, Dr. R. Hariyara Prakash sir, whose guidance and leadership have been instrumental in shaping the success of KAA Talk. I welcome you, sir, to deliver the opening remarks and set the tone for this inspiring session.
Very good morning.
Good morning.
You heard the nostalgic prayer. This is something unique to our campus. This Sabadharma Prarthana will take you to a different zone. I'm sure you would have got goosebumps sitting there. And maybe to add on to that, they have kept it in full volume. Right. So very warm welcome to all our students, our faculty members, and few who have joined us online. So it's a wonderful occasion that we could able to bank upon our own alumnus who have been prominent in this field. After graduating from here, you could see their profile over here. They have got their post-graduation from one of the best institutions in the country, and one is already a PhD holder, and both are doing very good work in their clinical practice. So, as every time when we arrange this KAA Talk, I just give a brief background. So, I just take a couple of minutes. Already we are late by 20 minutes due to some technical glitch. But thanks to them that they are not leaving immediately after this, as they are from far off places, so we may end before 1 o'clock. So I leave the stage to them. So this KAA Talk was initiated some 3-4 years before, trying to bridge the gap between the institution and the passing out students. Because after one point of time, like how a parent feels proud when you are known that he is father of so and so. Like, you know, many of my people in the society knows me as father of Raghav Madhav, something like that. So same is the case after one point of time. Institutions take pride when people know the institution through our alumni. You know, this is one thing which we cherish. And every institution, as you always say, Harvard or Oxford or all, just not buildings. Maybe initially to start with, it is an institution, but later the name, fame, Stanford, everything came because of those people who have achieved something in their next milestones after completion of their studies in that institution. Stanford stands out, Oxford stands out, many institutions, because of the alumni, it is well known to the society. So to have that big dream in our institution, we started this alumni association. To be very honest, we are doing well in academics, we are doing well in clinics, we have good community outreach, but we were very poor in linkage between the institution and the alumni. So we celebrated last year 25 years. You can see the logo on both the sides. That was the logo which we released. The roots are golden in color because Charukar Arogya Mandal has crossed 50 years. It's a golden jubilee, so golden. And on top of it, the leaves are all silver in color because we are 25 years. So we are silver leaf on the golden roots. So heading towards our golden jubilee. So 25 years is not a small period for an institution to be in the society, offering quality education, patient care. And that means that you have so many people out of this institution who are serving across the globe, either in academics or clinical or research or administration, so on and so forth. So it is a platform which we wanted, that we need to invite such alumni who are doing well. It is not about only prominent alumni. Whosoever feels that I am capable of now giving back to the institution from where I got my education are welcome to come over here. And sometimes we approach, sometimes people volunteer. So that's how we started way back. First KAA Talk, I remember that was by Payal Talot, who was our very old student. Even before me, she passed out from here on time management, and it all went on, and now we are in the 13th edition, and where we have two prominent female alumni whom we fondly remember always because of their punctuality, the way they took academics sincerely, with the dedication when they were with the patients. And I remember RC's in the hostel. When I said that we will book accommodation in the VIP guest house, she said, "I will be happy in the hostel." Because students always remember the place where they had fun. They don't want to remember the classroom where they were been studying or scolded or sincere. It is always those moments where they had fun. We always want to remember. So that's nice of her, that it is just not about having fun. It is about the humbleness, that I'm okay with wherever it is. So it is an example. When we say that we are this, that, more than that, in our alumni who has experienced their education, who had made use of all the infrastructural facilities and all those resources of this institution, if they fondly recall whatever that they have gained out of this, adds value. So it is equally a blissful situation for us as faculty to see our students doing very good in their routine clinical and academic and administrative life. But it will be heartening for all of you also as students, that you can see next 5 years down the line, you will get inspiration from them. Okay? So this is part of our week-long celebration, World Physiotherapy Day, as we kick-started it on last Monday, and we'll be completing it on coming Monday 8th, which is the D-Day, where we are having an interprofessional approach, where a neurologist and all those multiple professionals come together. We are going to have a good talk on falls prevention. Okay, so I'll not take much of time. Already we are late as we started the program due to various reasons. So I'm very happy to extend a very, very, very warm welcome to RC and Shraddha to this campus, from where they have become the physiotherapist. And I extend the warm thanks to our KAA University, the faculty, alumni coordinators who have coordinated for making this event happen. I should say they have travelled all the way in this thunderstorm and rainy day. One from Keshod, another from Mumbai. So it's not an easy, that's the dedication. I should definitely thank you for that. You have come physically. You could have asked for a webinar, which is nowadays possible, no? Dunia Mukti mein hai. You could have done this online. But that shows how much, they are happy to come back to the institution. This is what we want. And we want such alumni sitting over here to come back 3 years, 5 years, 4 years down the line as you are moving towards your end of your career here. So my best wishes to both of you, and we always look forward to hear good things about you, which we can share fondly to our younger generation. Over to the MC, Disha, to take it over. Thank you so much for coming and accepting the invitation. Enjoy and learn things. Feel free to talk to them, because they are just your seniors. They were everywhere they have placed their foot. So talk to them, interact with them, ask anything related to subject or about education, anything, whatever. So they are going to be here for the whole day. So even though their session is over, so feel free to interact. I hope you don't mind that. Thank you. Bye.
Thank you so much, sir. It is my pleasure to invite Dr. Ashish Gupta, sir, who will be introducing our esteemed speaker for the 13th part.
you very much. Being an alumni coordinator and teacher, I feel privileged to introduce RC. And the meaning of, if I need to introduce her in one word, the meaning of RC is a light or rays. She is a very bubbly and knowledgeable energy. So, RC is a 2016 alumni batch alumnus, and then she is a neurophysiotherapist with inclination for coma arousal therapies for disorders of consciousness and clinical neurorehabilitation. She has, after her BPD, she had done her MPD in neurophysiotherapy from Manipal University. She had completed in MPD in 2018. Later, after that, she earned her PhD in neuroscience disorder of consciousness from RK University between 2019 and 2023, and pursued, after that she pursued fellowship in intraoperative neurophysiological monitoring from CMC Vellore. So it shows her dedication to know the what we call is the good rahasyas of coma disorders and neuroscience, her love towards neuroscience. Now she is a founder and CEO of Neuron Neuro Rehab Clinic in Junagadh, which provides a comprehensive neurorehabilitation services including the cognitive perceptual rehabilitation, speech and swallowing therapy, motor and sensory retraining, ball-related rehabilitations, and inpatient care for individuals with complex neurological conditions. She also leads a Spurs Physiotherapy Clinic, KAA, which focus on integrative neurorehabilitation program. In addition, she is actively engaged in designing play-based, task-specific toolkits. Hopefully, she will show you everything to support the neurodevelopment and cognitive motor learning in children, particularly tailored for regional language and rural setting in Gujarat. So, if I need to describe her in other words, she is a very seva bhavi. She was the pioneer to establish what we call to set up the relationship between the KMPIP, Bhaikata, at that time Bhaikata University was not there, with Bachpan Institute of NGO. She was the most proactive therapist who was giving the services in Bachpan NGO. Bachpan you must have heard about, right?
After she went to this you only has invited this pathway.
Huh.
We continued for the
After that Priyansi used to go. Her work has been recognized with several prestigious awards and grants. In 2022, she received a Young Investigator Award grant from the Indian Federation of Neurorehabilitation, a chapter of the World Federation of Neurorehabilitation. For her PhD research, specifically she received a grant for her PhD research on subject-specific integrated multisensory simulations in coma. She has also been awarded a Student Startup and Innovation Policy SSIP grant for developing a play-based toolkit for children in rural Gujarat. Her academic and clinical interests include coma arousal therapies, task-based training to promote the neuroplasticity, dual task training, cognitive motor integrations, and early intervention strategies. And as you know, we are celebrating a World Physiotherapy Day, and today she is going to speak on early neuromarkers of frailty, screening and interventions, emphasize the crucial role of physiotherapy in early detections, prevention and promotion of healthy health. So, I feel privileged to welcome Dr. RC. Please come. Please welcome her.
Shraddha will introduce later?
That was so lengthy, sir. Thank you so much. On the way when coming from Keshore to Karamsad, I was just thinking about walking down the memory lane. Wanted to see all the places, this auditorium as well, from which we convocated. Thank you so much. It's such an honor, sir.
good morning everyone once again. I'm so grateful. And to begin with, next slide. I was also just like a student, like you are sitting, I think, in the corner with Shay and all. So it was 2011 and it is 2016. It was our first year group photo. And then this very stage from which we constituted. I still remember the candle thing which we do as a part of Karaka. It's so special. And what a special day today, because yesterday it was Teachers' Day. All these wonderful teachers who have helped me, Ashi sir, Yoma ma'am, sir, Haryana sir, and we have World Physiotherapy Day. They have helped me become the therapist that I am today. It wouldn't have been possible without them. So I'm so grateful to be standing in the middle of these 2 days and presenting my talk. So I work predominantly into the neuro rehab area. In Keshod, we have a pediatric neuro rehab setting where we do a lot of applied behavioral therapy for autism, for cognitive disorders, for learning disabilities in pediatrics, which is likely not mainstream rehab like we do NDT, dynamic movement therapy. We do comprehensive neuro rehab for pediatric patients since 2018. And recently I started a clinic 6 months back, that is Neuron in Junagadh. That focuses predominantly only on adult neurological patients, where we admit the patient into daycare facilities from morning 8 till evening 6. And we have a team of speech swallowing therapists, bowel bladder therapists, and we give 5 or 6 sessions a day, holistically managing the head injury patients, spinal cord injury patients, like that. So that was a brief about me. Today I'll be presenting the topic early neural markers of frailty. Now why I thought about this topic was because you all will get married one day and then you'll be living apart from your family and your father and all. So I would always want my teachers to age healthy. I would always want their integration into the society in a functional or in a healthy manner. So when I think about my father, I think that he has become a little weak, he has lost a lot of bone density. So is there anything that we as daughters can do for our parents or even for patients, wherein we can pick up early the markers of neural declination before it precedes the sarcopenia, before it precedes the muscle loss or something like that? So that was my interest, and then Ashish sir communicated and sir chose this topic, for which I'm so grateful, because this is the message that really needs to be passed on. And that is how I came up to this topic, that is early neural markers of frailty. So we will be seeing what frailty is, and then we'll be seeing the markers, how we as therapists can just pick up. We don't need any advanced tools or any advanced instruments to pick up. Just by seeing the patient roaming around, we can just make out. So I'll give you some brief tools and screening indicators, and then how we intervene on them. So the management part we'll discuss. So coming to the topic frailty. So frailty is a state, it is not a disease. There is disability, a patient is disabled in the bed, and there is aging. So frailty stands in between aging and disability. So any patient who is crossed 55 or 60, and if he has IT femur fracture, he'll become disabled for some period of time. So anything which stays in between disability and aging is defined as frailty. So it's a condition, or it's a state that every individual goes and becomes vulnerable because of declination of multiple physiological systems like cardiorespiratory system, CNS, nephro, musculoskeletal system. And they are unable to cope up with the stressors of every day. Like they go out and they fall sick. They roam around and they fall. They end up having fractures, which they usually will not have if it was 15 years back or 10 years back or something like that. So the adaptability to everyday stresses also reduces, and they go into a state wherein they are more vulnerable. They do not have enough reserve into all domains. And that increases the risk of adverse outcomes like disability, cause hospitalization and death. It is often associated with aging, but not always. Young people can also get into a state of frailty, and the important thing to discuss is that it is reversible. So, know that he must be of the age of 75 or 80 or something like that. He's frail for sure. He has a lot of weight loss. You can see his little cachexic. He has low energy, very slow gait. Uh, his muscles are also lean, not much of muscle protein. He struggles to recover frequent URTI, LRTI. He keeps having hospitalizations multiple times a month. So this condition you can say that is of frailty. Okay. So frailty affects the multidimensional system. All the systems are involved, not one condition or not one system, all are involved. And it's not a fixed state. If I intervene something over here, then something can be changed. His vulnerability can go down. Okay? So it is a stage between normal aging and disability. Moving to this one, you can see that this is a pre-frailty condition. That Dada was to frail only. But this is how the frailty starts. So this patient was presented to our OPD, and the wife was very much concerned because both of the children were staying into United States, and then she was concerned that he is not interested into anything. He doesn't even want to go to peanut mill, and he doesn't want to work at home. He's not happy with me. So these are the concerns that the wife was complaining. When we assessed, he was already into the state of clinical depression, you can say, because he was not able to perform his ADLs and instruments of daily living. ADL is something like eating, bathing, yeah.
What was the age of the
So ADL is something like eating, bathing and all. And instrumental daily living activities incorporate like dealing with the cash in the mill, dealing with the projects at the workplace. So that was hampered, which led him to low mood, and that led him to depression. And then he was very slow. He had bradykinesia. He had poor gaze. He had poor control. Smell was not there. So these are the clinical signs which are preceding the loss of muscle strength or bone loss. He's not having any bone loss or loss of weight or anything like that. So if he does not do anything at this stage, after 10 years for sure he'll be like that. Ajay, right? So these are the clinical symptoms of pre-frailty situation.
He's not diagnosed with any neurological.
Recently he is diagnosed with atypical Parkinsonism query. It is not yet
In the
fixed.
time span of when did you meet him and when he is that time he was not diagnosed?
No, that time he was not diagnosed. He had been to a neurophysician. This was before 8 or 9 months.
So you suspected?
Yeah, we suspected Parkinson's. Yeah, because you can play that video, another one.
Okay, the face is also masked like there was in that time also.
The other video. So the cliffhanger. પછી કેટલા ટાઈમથી થાય ઓકે પછી સ્મેલમાં ક્યાંથી ઇશ્યુ છે 8-10 વર્ષ સ્મેલમાં ક્યાંથી પછી બેલેન્સમાં શું તકલીફ થાય તો અત્યારે તમે સ્કૂટર ડ્રાઈવ કરો છો કે આંટી ડ્રાઈવ કરો ઓકે એટલે પાછળ એમને પગ રાખવા પડે એની એમપીટી ન્યુરોપીજીસ દેર આર સિટિંગ yeah. So Parkinson's disease is Parkinsonism is a spectrum under which comes atypical Parkinsonism, right? So these are all the characteristics of classical Parkinsonism. What he said was anosmia, which precedes all the other symptoms. 15 years back he had anosmia, loss of smell. After that slowly he started developing loss of interest, anhedonia, and a lot of issue in balance. He is not able to ride the Activa now, right? So that is his major complaint. And with that he came to us, he presented to us, right? So I think you are clear on what frailty is in the clinical setup, right? So the next. So now I want you to understand that every individual who ages, they do not age like that. They can also age like this, right? They can also be strong, they can be independent, they can perform their all activities, they can integrate in the society into their own ways as per the age. A 65 lady can integrate as per a 65. So this is just a message that I wanted to say, that this is possible with a good body hygiene and a good mental care. Right? So this was about frailty. Now, yeah, no problem. That's absolutely fine. Yeah, sure. So now I want you to shift your perspective little from frailty only as a musculoskeletal condition. कोई भी old age આપણે જોઈએ તો એને ખાલી bone loss પર જ આપણે ફોકસ કરતા હોય કે muscle loss પર જ ફોકસ કરતા હોય. Weak થઈ ગયા છે ને. Nobody focuses when they say at the age of 45 or 55 કે મને યાદ નથી રહેતું. Right? We have our parents who say કે મને યાદ નથી રહેતું પહેલા જેમ રહેતું એમ. હું થોડું સ્લો થઈ ગયું છું. ડ્રાઇવિંગ સ્કિલ્સમાં થોડું ઇશ્યુ આવે છે, જજમેન્ટમાં ઇશ્યુ આવે છે. રાત્રે કાર નથી ચલાવતા. હવે દિવસે જ પ્રેફર કરીએ છીએ. So that all comes under a neurological frailty, which is diagnosed much earlier compared to a musculoskeletal frailty. Right? So earlier it was seen as a physical or musculoskeletal decline, but now it is more seen as per NHS as a neurobiological syndrome, and wherein we see that neurological decline happens much before compared to a muscular decline. So the thing we have to focus is physiotherapy can help, and how it can help is we have to screen early, we have to see the neural markers and then intervene timely. So now these are the neural markers that you see. First is executive dysfunction. We all know frontal lobe disorders, Dani, side and Emuti. That signifies how good my prefrontal cortex is, right? You all can do Tani, side, Muti. That is prefrontal cortex. A loss of inhibition would lead to like this or something like this, right? So when the prefrontal cortex deteriorates over time or as a part of aging, you have executive function dysfunction. Like working memory will be less, the patient will complain कि याद નથી રહેતું, attention span ઓછો થઈ ગયો છે, interest ઓછા થઈ ગયા છે, ખાલી રીલ જોઈ રાખે, driving slow થઈ ગયું છે. So these are all the executive dysfunctions. Next is reaction time delay. How they used to react to situations or how they used to react to a stimulus was much fast compared to now. Another would be during task difficulty, like walking and talking, or talking on phone while cooking, the jai jayega, todai jayega, speed ochi thai jaye. These are the things that you can pick up into your parents as well, right? Then gait variability, they become slow, they become slouch, or ek side per deviation thai jaye. Next is postural control deficits, we all know. So this all happens when you look at the brain in general, it happens because of PFC, that is prefrontal cortex degradation, loss of neurons in that area. In the cerebellum, cerebellum would lead to balance dysfunctions. Basal ganglia would lead to vestibular dysfunction, tone dysfunction, a lot of cachexia would happen, right? And white matter dysfunction will lead to reaction time difficulty, then execution difficulty, atki jaye, hesitation થાય, and procrastinate કરી રાખીએ. So these are the areas in the brain which get affected as a part of frailty. That is what I wanted you to relate. કે આમાંથી કેટલા લોકોના parents you have heard speaking this all? You have heard, yeah. So he's into a pre-frailty condition, my dear. And then if you intervene at this point of time, he can have a very good healthy aging, right? And what I want you all to take home is that you should assess frailty as a multi-system thing, and you should also design your intervention as a multiple system thing, not just the musculoskeletal part, not just lifting weight or not just strength training or not just aerobic exercises, not just walking, but a lot of cognitive motor integration should be performed, right? Am I too fast, sir? Is it fine? Okay. So this is something which we have developed out of a systematic analysis that was there in this article, and they're very nicely given some simple indicators. There's no need of any investigations, nothing is required. The first is gait speed. Gait speed of 0.8. Abdo neuron jo treadmill hoy, that starts from 0.5, right? And orthopedic treadmills usually start from 1 or 1.2 if I'm not wrong. So if any gait speed of less than 0.8, that signifies that basal ganglia and cerebellum are not in rhythm, right? So gait speed reduces. Second is chair rise test.
You are the patient who sit over here. You need a lot of musculoskeletal strength, right? You also need a lot of initiation from basal ganglia. You will be able to execute it ask like this. He'll have hesitation like this. કાં તો ધીમેથી પહેલા આગળ આવશે પછી અહીંયા ટચ કરીને પપ્પા થશે. So chair rise test for more than 12 seconds is signifying that
muscle strength is an issue, right? Single leg stance.
Like how we do tandem stands, eyes open, eyes closed, room work, so that we have to perform first. That single leg stands on normal days of, on normal floor, not on foam or anything like that. If the patient is able to stand for more than 5 seconds with eyes open and more than 5 seconds with eyes closed, that means it is normal. But still, he could have near normal range, like 6 or 7 seconds or something like that. Normal would be 25 or 30 seconds for us. Right? So anything less than 5 seconds is
Suggests that the patient has cerebellar issue with prefrontal cortex issue. I will come into single leg stents later. What all systems are a part of single leg stents and how you can assess just from one test. Next is tug. Tug we all do. More than 12 seconds is, I remember Ashish taught us tug. BP machine and SPO2 probe like that. He used to scold us. Then postural sway you have to observe. Is it at the level of ankle? Is it at the level of hip? That also suggests a lot. Then simple dual task training like walking and talking, walking backwards and talking, walking and cooking. Right? And cognitive perceptual tools like clock drawing test. He would not address the time properly or would be very slow. The clock would be very small. That would be micrographia, small clock. Trail making test. Trail means A, B, C, D. You have to write distinguished on the paper, A4 size one, and then they have to connect the letters. It could also be a complex task like 1A, then 1B, 1C. Like that way you can make a trail, right? It also assesses the prefrontal cortex. So this was the bedside indicators, which we all can do. Now for PGs, if you want to go further into the detail, a gold standard scale, which has the highest level of evidence in order to assess the pre-frailty group, is the Frail scale. This is the Frail scale. So FRAIL stands for fatigue, resistance, ambulation, illness, and malnutrition. Right? They have a scoring range of 0 to 5, and 1 to 2 is pre-frailty. So this also you can assess. This is a very good scale which addresses almost all the components and all the systems. Other we have clinical frailty scales, ADL and IADL impairments. If you are suspecting a patient is not able to perform his vocation, if is presented early, less than the age of retirement, 58 na pehla koi patient aave, then you should take the IADL scale because you want to know ke occupationally કેટલું affected છે, કેટલું hampered છે એનું aging process. And then short physical performance battery. It is more of, I think Shraddha will be taking it, more of aerobic based scale. So these are the screening tools, more for academic purposes and more for objectifying the pre-frailty group. Now why early detection matters? As I said, the myth has changed. 2022 Sudhi frailty was only considered musculoskeletal or cardiorespiratory thing. After 2022, NHS in UK very diligently revised the definition of frailty and added mental health or added the neurocognition part to the definition of frailty. And they said, as per research, that CNS decline precedes almost 10 or 15 years. 10-15 years, my dear, is a very long time in which you can intervene, you can change the trajectory of your life, you can change your habits, you can change your lifestyle, and you can change the outcome, right? So early detection matters because if you are able to diagnose the prefrontal cortex declination much earlier compared to the muscular loss or the bony loss, you can intervene and then you can help them towards healthy aging. Now coming to the management. So what all you know? How we intervene into geriatrics? How we help them age normally? Considering only the neurological aspect. Neuro PGs can start maybe. Yes.
After the frailty has, after the first case of the,
Yeah.
first we used to focus on their gait patterns, balance training, their strengthening exercises, and basically to reduce the falls.
So heat માટે what you will do?
For gait, we will start on the mat. We will start with some PMF activities, and then on standing, we used to go with the parallel bar training, and then stretching and everything.
You're talking about frailty group, the person who's already affected.
Already.
If you want to treat maybe Ashish sir from now, sir is I think 45? 41. Hariyara sir from now. He's into frailty group. He's 50. So in next 15 years, maybe he'll be 65, right? So you want to treat him from now. So what type of task he should be doing into his daily life so that the trajectory of his aging changes when he ages normally.
I think you told us that we have to start looking for the neural markers. So for Hariyara sir, if he starts having some of those neural markers, we can stop it at that time itself. We can educate him. Like we can educate, he might know about it, but we can educate the patient about કે તમને શરૂ થાય છે. So like you said, the dual tasking we should start. We should start engaging them in the home activities itself first of all. So okay, bed rolling and in सब में भी उनको अगर problem चालू हो जाता है तो first we'll work upon that and then we'll go forward into anything ahead.
So, as for a cohort study, first I would like to, I was talking about single leg stands, right? Only one test is required in order to see the neural markers change. So, what are the components of balance? If I want to stand here like this, can the model? So you have to stand on one leg. You have to assess on both the legs. Okay. And let's first single leg stands with eyes closed if she is standing. Which are the systems that we are seeing neurologically? What system is firing at this point of time? She's having a rest. Very good. Yes. Proprioceptors of ankle, knee, and right side in neck, and pelvis. Yeah. What next? Eyes closed. So what is working? Vestibular system, yes. The vestibular cerebral
Sensory system.
Yeah, sensory system would consider that. These two are part of the sensory system. Now, you open your eyes and you take
Motor control.
yeah, the muscular level.
Basal ganglia was also basal ganglia and cerebellum were also working to balance the upright posture.
Focusing on doing that. Yeah. So prefrontal cortex is also working. Yes, it cannot be without that. No, she needs a lot of attention. She needs a lot of execution, precision, accuracy. Those are all the part of prefrontal cortex. Right. So when we look at the sensory part, with eyes open, her vision is helping. Vision एक बार affect करे પછી तो कहीं help ना करे. ये બધું બંધ થઈ જાય. But when the vision is not working, actually those two systems hits it. Right, the vestibular and the proprioceptive. So if you want to assess those two, it should be eyes closed. Normal ways of support, narrow ways of support, on foam, on dynamic foam. That ways you can assess. Next is the motor part, as she said. Those all are working. The cognitive part, as I said, that she has to pay attention to, she has to strategize, she has to execute. So the cognitive function is also working. Yeah, she just.
નથી સંભળાતું. Okay, I'm so sorry. Right, so whenever we do a single leg stance, there's an integration of all the systems that plays a role, and that is how normal one leg stands while the gait we have double support phase, and then we have a stance phase and then the swinging phase. So in the stance phase, these all systems work, and that is the first indicator that can be assessed in an healthy adult of 50 or 55 age group, right? So from this only you can assess which system is affected. Now this says that the aging occurs in all the parts of the brain, and firing of all those areas is responsible for a normal balance or a normal gait. Okay. Now coming to the physiotherapy management, the highest level of evidence which is available so far, તમે લોકોએ કીધું કે task based training, dual task training, You all said the motor training. Shraddha will be covering the aerobic part. Those all were there till 2022. After 2022, what came ekdam light was the cognitive motor integration training. And if not anything, this is something that you can take home today. The cognitive motor integration training says that there has to be a challenge given to the cognitive part and there has to be a challenge given to the motor part as well. ચેલેન્જ એટલે નોર્મલ ગેટ પર જ વોક કરવું એવું નહીં, સ્પીડ બી વધારે હોવી જોઈએ કાં સ્પીડ ઓછી હોવી જોઈએ, ટ્રેલ્સ અલગ હોવા જોઈએ, રોડ્સ અલગ હોવા જોઈએ, એની સાથે યુ શુડ બી ડુઈંગ સમ મોટર સમ કોગ્નિટિવ ટાસ્ક. ડ્યુઅલ ટાસ્કમાં યુ આર જસ્ટ ડુઈંગ ધ ટાસ્ક ઓફ ડેલી લિવિંગ લાઈક eating and talking. There is no cognitive load or cognitive challenge to dual task training that had the highest level of evidence till 2022. So cognitive motor integration task is any activity where the brain must simultaneously process a cognitive demand and a motor demand, right? And it requires an interaction between higher order cognitive processes and motor output. So these are the areas that work together. That is how I said the entire brain has to fire together in order to address the pre-frailty condition. Then we talked about dual task training. જેમ એક્ટિવિટીઝ ઓફ ડેલી લિવિંગ હોય એમાંથી કોઈ બી પે ટાસ્ક ચૂઝ કરી લેવાના, then you give those tasks to the patient to do. Next is balance training. You all I just saw neuro OPD man, you all were taking the patients on foam, on posturography and sensor move. Yeah, so these all are a part of balance training. So you are targeting which system? Balance training ma the cerebellar and the vestibular, even the basal ganglia parts by giving good commands. Okay. Next comes aerobic exercise. The major advantage, considering the neurological perspective of aerobic exercises, it boosts the BDNF, brain-derived neurotrophic factor, and that improves the hippocampal area. That improves a lot of prefrontal cortical synapses. So that is how every patient who comes to you into the pre-frailty group, every adult should be doing aerobic exercise at least 5 times a week as per ACSI. Resistance training for the musculoskeletal component and task-specific functional activities. The neurons that fire wire together, so this is the management. This is all you know, but the only thing which is new is cognitive motor integration training. Now, practically, hands-on will be seeing how we do cognitive motor integration training. Okay. Innovative approaches. You had some part of our physiotherapy day celebration. So what are games you played there with adults there? Yeah. So it was a low-cost community-friendly intervention. Correct? It will also address all areas of career. That's how it will address training. Done daily, increasing the motor cognition challenge, increasing the motor physical challenge. That is how you can calibrate the exercises for them or games for them. It was something fun-related, fun-based. Another could be play-based activities for cognitive motor activation, group-based therapy. You did play skit or something like that. That also comes under that. And then technology assisted. You have Xbox, VR, right? So what is the role of a physiotherapist in addressing pre-frailty? First is early identification and intervention, and designing a good motor cognitive plan or motor cognitive intervention. That is cognitive motor integration training. So we'll need the table and a chair and one mark.
Part of my
Actually, in 2018, in 2018, I was doing a research on children in rural part of India. Saurashtra, the education, the quality of medical care is very poor. And 2019, COVID was there. So I wanted to treat children with cognitive training at home. So we developed kits for them so that they can intervene at home and we would not miss on the COVID part at school. So then slowly we commercialized it and named it as Spella, S-P-E-L-A. Spella is a company that produces toys for pediatric people. Till 2020, after that I started using it in adult patients. So I would want one model. So it was about cognitive motor integration training. How we design a treatment which focuses on challenges into cognitive domain, which focuses on challenges including the motor domain, and how we integrate it into the treatment profile for pre-frailty group guys, not for frailty or not for aging population. So this is a sheet, for example, right? So this needs a lot of attention. It needs a lot of prefrontal cortex activation. And I have to know in the memory, color, in occipital lobe, parietal because I am feeling. So parietal lobe is also activated. So all parts of brain are activated. Now I want to stimulate the basal ganglia and cerebellum. So I will. Thank you. So we have Deepa. For example, she is 55. Okay. So we'll make her stand on foam. So that would be a challenge as far as the motor part is concerned. Then what Deepa has to do is one leg standing also she can do, and then we have designed various levels of this. So this is level 1. It is the easiest. What she has to do is she will be having cards of various colors like this, yellow, red, pink and all. And in this sheet she has to do this designs simultaneously while doing one leg stands. Okay. So can you do this for me, Disha? This is the thing. There can be a timer. There can be another challenge of time so that you are addressing another part of the brain. You're not supposed to take support. Balance board से आपकी person. She can stand on the balance board. Very comfortable. Come. This is fine for you? Yeah. So this is the pattern that you have to design. These are the colors that are there. You have to design it from this. As fast as you can. Okay. So she did that, right? It was this challenging? No, not that much. One leg will be challenging. If I change the surface over here and here and here and there, it will be more challenging, right? So what she did was, in a green chain, first stage, second mark put kariyu. That means that she is little rigid about starting from first. I was also rigid કે exam ના આગલા દિવસે first chapter થી જ revision ચાલુ કરવાનું. વચ્ચેથી revision ચાલુ થાય તો મજા ના આવે. That shows how rigid our prefrontal cortex has become. First એટલે first stage. You should do tasks like અલગ number, like 7 times chanting કરવાનું, કાં તો 7 times rounds કરવાના. બહુ round figure પર focus નહીં કરવાનું. That shows that we are very rigid. That also leads to a lot of degeneration in the brain. You need to do that. If high nahi to dopamine generate na થાય, right? So she started ayathi. She could have started ayathi. She could have treated the pace started ayathi. Anything would have been possible, right? So this was just a small example. Another example which we can give is this was regarding the occipital cortex, the parietal cortex. Her motor system is also reacting. Her proprioceptive system is reacting. Her muscular strength is reacting. Her cognition was also taking a part into it. Her IQ was taking a part into it. So holistically, we are addressing the entire cortex. Also with the diagram was there. The entire cortex synapses are firing together. So you should have that. If you see functional MRI at this point of time, attaching all the electrodes over a head, you will see a lot of firing from all the areas of the brain. That is how you can do the cognitive motor integration. Another example which we can give, you can change the model. Fast, you can change the model. Thank you. Thank you. This is more so for the dominant cortex. These are various patterns like A, B and C, right? So this is purple, blue, green, purple, blue. What will come next? As per the ABC pattern, green should come next, right? So we have designed 4 colors like this. They have to finish the pattern. Now here she can have a treadmill, and on treadmill she can perform that exercise. No problem. Consider that this is a treadmill. right? So that is a motor task that she has to do, and this is the cognitive task that she has to do. Can you do as quickly as possible? No, no, no. What is?
Or like what's
Yeah,
missing?
what's missing? Good. She was too quick, right? So pre-frailty માં ન થાય, થોડી વાર લાગે એ લોકોને. You can also change the heights and the areas. So this is just an example of cognitive motor integration. I have further uh, demonstration as well, but we can take it later if you guys are interested, right? So just my take-home message. Thank you. Just my take-home message is that physiotherapists can delay or reverse the frailty if diagnosed early based upon the neural markers which are so easy: gait, speed, chair right, stress, single leg stance and tug. Screening tools Frail, and then you can design a very good cognitive motor integration training along with those 5 areas: dual task training, aerobic and motor. Right? So there's hope still, and we can just land a hand to that. So that was all I wanted to share. Thank you.
The stage is open for the question answers. If anybody has any questions. No questions?
એક જણ માઇક આપી દો.
I have one question. During the frailty period, we have to increase the independence of the patient that they can do their ADLs by themselves only. But what I face challenges is sometimes some patients need the walking aids like cane or walker or even wheelchair. It is there to increase their independence. But through their life, the whole life experience, they have been independent throughout their life and so with their principles and everything. So psychologically it is very difficult for them to accept those walking aids and everything. And even while depending on others, they will be more frustrated and anger will be there. So how to deal with it?
So you are asking about frailty. Already the situation is there. Already they are frail. Yeah. So you can slowly introduce them. You can give them strategies with which they can improve the overall system. Like we said, everything can be started together. But along with that, you can just educate them about safe fall strategies. You can say that that is not something which we want to go ahead for the rest of your life. Just for time being, you can just take so that you are safe or something like that. The thing that we wanted to discuss was not frailty. We wanted to discuss કે patient ત્યાં જાય જ નહીં. We fail group જે હોય એનામાં જો intervene so that that stage does not happen. If that happens, for sure the patient will come to Shweta ma'am for neuro rehab. And we as neurotherapists are going to address all the parts. But our idea of intent was કે એ ત્યાં પહોંચે જ નહીં. That was preventive. Right? Thank you.
Hello. So we have seen our parents and they are growing now, like 50s now already they are. So they have started having this on as parents. So now if we want to incorporate in daily activities without them noticing, first of all they won't accept okay we are declining or we are aging, okay, the main problem. And even mothers would accept but fathers will not. They with their ego will get hurt કે નહીં મને કઈ નથી થતું, why to do any therapy. So if they are not accepting, how to incorporate activities which will like strengthen the cognition also and decrease the frailty, the speed which is decline is happening.
Very nice question. You're concerned about my father. Same like I was also concerned about my father. There can be two answers to this. As a daughter, I'll answer differently. Like try કરતી વખતે songs play કરવાના, કાં તો કંઈક બી એવી cognitively challenging વાતો કરવાની, ત્યાંથી you can start. है ना? પછી take him to more of open areas, incorporate different footwears, incorporate different trails while going back home, coming to home, अलग अलग રસ્તાથી જવાનું, left hand થી brush કરવાનું. That increases a lot of neuroplasticity. As a doctor. Now as a therapist, you are a neuro PG, right? So what my intent was that when we focus on cognitive motor integration, how you design a task for a patient is બધા જ પાર્ટ્સ પહેલા એડ્રેસ કરી લેવાના. પ્રીફ્રન્ટલ, રાઇટ એન્ડ લેફ્ટ, ડોમિનન્ટ, નોન ડોમિનન્ટ, આમાંથી એક એક્ટિવિટી, પરાઇટલમાંથી એક એક્ટિવિટી, ઓક્સિપિટલમાંથી એક, ટેમ્પોરલમાંથી એક, સેરિબેલમમાંથી એક, બેઝલ ગેંગલિયામાંથી એક, પછી મસ્ક્યુલર લેવલે બધા જ મસલ આવી જાય. એ રીતે કોઈ બી એક પોઝિશન છે કે સ્ટેન્ડિંગ છે કે વોકિંગ છે કે વન લેગ સ્ટેન્ડિંગ છે, ઓલ્ટરનેટ સ્ટેન્ડિંગ ઓન ફોમ છે, એ આખું ડિઝાઇન કરીને પછી જોવાનું કે એડીએલ શું છે પેશન્ટ. For example, patient was a sports player, so then you need some more challenge, more partner. Now make something more challenging into the cognitive domain, addressing all those areas, and into the motor domain. But she come up with a task. One like standing with agility, motor activities, and then you can execute. You have to keep on increasing the challenge every 4 or 5 days because now synapses they form, and then that pathway is stabilized. So you can only see the improvement when you keep challenging the cognitive and the motor part both. Thank you so much. Yeah. So we are right. Yeah.
मैम अगर किसी को जैसे कोई पेशेंट हमारे पास आया अगर हम उसको डुअल टास्क ट्रेनिंग कराना चाहते हैं बट ही इज टेलिंग दैट ही इज नॉट एबल टू डू इवन वी ट्राई लाइक इफ ही इज वॉकिंग बट वी ट्राई टू टॉक टू हिम बट ही स्टॉप्स जैसे ही बात करना स्टार्ट किया ही स्टॉप्स सो व्हाट शुड वी डू नेक्स्ट टू इनकॉर्पोरेट दैट डुअल टास्क ट्रेनिंग इनटू दैट
So usually you can start with the normal physiological walking speed of the patient. For example, it is 1.2. So you just lower the speed, that is 0.8 or 0.9 or something like that, and then introduce the task. If that is also not working, you strengthen the speed. Start from 1.2, go up to 1.82 or something like that. Once one task is fully secured and stabilized, then at a lower speed introduce the other cognitive domain. You can just say by lifting one hand, yes or no questions, right? Above, below, forward, backward. These are the easy concepts that the brain understands. From that base level conceptual training, then you can build up upon the cognitive part and gradually increase the challenge. Okay, so we are
Thank you.
short. Yeah, thank you.
Thank you so much, ma'am. Moving ahead at today's 13th part of edition, I would now invite Dr. Jigar Mehta sir to invite our second speaker for the day.